Assalamualaikum class. I hope you are doing fine. So we are going to continue with our lecture. This is the week, second lecture of the week of medicine 2, and our major topic is renal diseases. We have previously covered topics related to renal diseases like glomerulonephritis and UTIs. Now our next topic will continue from here on onwards. Before continuing with the lecture, I would like to tell you about some important elements of this lecture, and that are the learning objectives. From the lecture moving forward, we will see or discuss disease process and the management of renal pathologies like renal hypertension and renal failure. After these lessons, students will be able to explain the difference between important renal pathologies. By the end of the lesson, students will be able to identify causes of acute and chronic renal failure. So let us continue with our lecture. The main topic of this lecture is about hypertension and its effect on the kidneys, or more specifically, how hypertension influences the function of the renal system. First of all, I would like to talk about briefly what is essential hypertension, which is our first topic. So, when talking about essential hypertension, this essential hypertension leads to characteristic uh, histological changes in the renal vessels and the intrarenal vasculature over time. Changes can include the intimal thickening with reduplication of the elastic lamina. The elastic lamina is basically the covering of the blood vessels. Uh, Apart from that, there is reduction in the kidney size and increase in the proportion of the sclerotic glomeruli. I have briefly discussed what is a glomeruli, tough vessels, and sclerosis means hardening. So these vessels become hardened and their normal function is disturbed. So you can assume that this is then accompanied by some deterioration in the renal function. Another more severe type of this essential hypertension is the malignant phase hypertension or the accelerated hypertension. This is marked by development of a fibrinoid necrosis in the afferent glomerular arterioles and the fibrillary position in the arterial walls. If you remember the lecture previously, I have talked about afferent and efferent arterioles. So the afferent arterioles undergo a fibrinoid necrosis in this malignant phase hypertension. Apart from that, there is a rapid rise in the blood pressure, which may trigger these arterial lesions, and a vicious cycle is then established, whereby the fibril deposition leads to renal damage. Now, as this renal damage occurs, it increases the renal release and further increases the blood pressure. If you remember, renin is uh, a hormone that actually constricts the blood vessels. So due to constriction, there is an increase in the blood pressure. Then following it is progressive uremia, and if untreated, uh, it can lead to death. The next topic is uh, renal hypertension. So let's talk about renal hypertension. This renal hypertension is also known as renovascular hypertension. This is basically the elevated blood pressure caused by a kidney disease. So then that means there is underlying kidney pathology that leads to an elevated blood pressure. Uh, Usually it is controlled by blood pressure drugs. But certain individuals with this condition can require angioplasty, stenting, or surgery on the blood vessels of the kidney. Uh, Moving onwards, let me talk about a bit more of this renal hypertension before we come on the topic that is third on the slides. Now, this condition is caused mainly by narrowing in the arteries that deliver blood to the kidney. One or both kidney arteries may be narrowed, leading to a condition known as the renal artery stenosis. As you can see here, these blood vessels are supplying the kidneys each. So a plaque or a certain something like that can lead to a block in this fusion of blood to the kidneys, and this condition is known as the stenosis. Now, what happens is when the kidneys receive low blood flow because of the stenosis, they act as if the low flow is due to dehydration. So sadly, the kidneys interpret the low blood flow as maybe there's dehydration going on in the body. So what they do, you can expect what will happen. They respond by releasing hormones that stimulate the body to retain the sodium and water. The blood vessels then fill with additional fluid, and the blood pressure goes up even more. So uh, this cycle worsens the condition even further. Now, the narrowing in one or both the renal arteries is most often caused by usually an atherosclerotic plaque, or also known as the atherosclerosis or hardening of the arteries. It has been seen that this process can lead to heart attacks. This atherosclerosis can lead to heart attack or stroke. Uh, Less common cause can be a fibromuscular dysplasia. Fibromuscular dysplasia is what? It is a condition in which the structure of the renal arteries develop abnormally, and the reason is usually unknown. Although renal hypertension does not have any does not display any symptoms, the narrowing in the artery usually cannot be felt unless it is dangerously high. Now, so the symptoms of severely elevated blood pressure can include headache, confusion, double vision, a bloody urine, or nosebleeds. The vast majority of individuals that have this renal hypertension usually never experience these symptoms. Renal hypertension can also cause chronic kidney failure, which we will study um, moving forward. Uh, Now, because there are usually no symptoms, a doctor may suspect renal hypertension when someone has uncontrolled high blood pressure, despite multiple medication, or has unexplained chronic kidney disease. So that is just an overview of what is renal hypertension. What we are interested in its effect is on the bilateral renal disease. So let us talk about this bilateral renal disease. So this hypertension actually complicates this disease, this bilateral renal disease. Examples could be chronic glomerulonephritis, reflex nephropathy, or analgesic nephropathy. So the mechanisms responsible for this are activation of the renin-angiotensin-aldosterone system. So what is this renin-angiotensin-aldosterone system? Class, you can pause the video and think for yourself what was this renin-angiotensin system. You can use the sources you have available to remember the renin-angiotensin system before I briefly explain it what it is, as this is extremely important in this disease, or in the understanding of this disease. So I hope you have paused the video and studied it for yourself. I will now briefly explain you what this system is, or what does it entails. Now, this system is a hormone system that regulates the blood pressure and fluid electrolyte balance. So, what is the mechanism? What happens is when the renal blood flow is reduced, your uh, the juxtamedullary cells in the kidneys convert the precursor protein and secrete it directly into your circulation. So this plasma then carries out the conversion of angiotensin, and it is then released by the liver. So I will repeat it again. When renal blood flow is reduced, juxtaglomeralar cells in the kidney convert the precursor renin into renin and secrete it into circulation. The plasma renin then carries out the conversion of the angiotensinogen released by the liver to angiotensin 1. Angiotensin 1 is subsequently converted to angiotensin 2 by the angiotensin converting enzyme, or ACE for short. This is found on the surface of vascular endothelial cells, predominantly those of the lungs. Now, this angiotensin 2 is a potent vasoconstricted peptide. Simply put, it causes vasoconstriction. Now, that causes the blood vessels to narrow, resulting in an increased blood pressure. Angiotensin 2 also stimulates the secretion of the hormone aldosterone from the adrenal cortex. Aldosterone causes the renal tubules to increase the absorption of sodium and water into the blood, while at the same time causing the excretion of potassium. This increases the volume of extracellular fluid in the body, which also increases the blood pressure. So, class, you can imagine if there is vasoconstriction and increased blood pressure, this will put strain on your kidneys and can lead to damage. So that was the renal angiotensin system. Also related to it is the retention of salt and water, which I have told you. What happens is that when there is a reduced flow, it is interpreted as being dehydrated, leading to retention of salt and water, which is leading to an increase in the blood volume and hence blood pressure. So this is how the renal hypertension mechanism is initiated. Next, we will discuss in detail is the renal vascular disease. Now, mainly what is this renal vascular disease? Mainly it is the narrowing of the renal arteries, usually due to atheroma, and classically occurs in patients with evidence of generalized atheroma. For example, like peripheral vascular diseases or coronary artery diseases. Now, again, I have told you that what is atheroma? This atheroma is basically an abnormal plaque, an abnormal accumulation of materials in the inner layer of the wall of an artery. As you can see in the slide, this is an abnormal accumulation of material within the inner walls of an artery. So what it does, what happens is this material consists of macrophage cells or debris containing lipids, calcium, and a variable amount of fibrous connective tissues. Now, the accumulated material forms swelling in this artery wall, which may intrude into the lumen of the artery, narrowing it and restricting the blood flow. So that means, class, that when this plaque continues to accumulate, swell or obstruct the normal function of the or intrude the lumen, which further leads to narrowing or restricting the blood flow. And if the blood flow is reduced, what will happen? I am giving you time to answer the question. It will lead to further retention in the water and salt content, leading to further increase in uh, blood pressure. Uh, so it has been seen uh, that renal perfusion pressure is reduced and renal ischemia results in reduction in the pressure in the affected glomerular arterioles. So moving onwards, what we have to talk about in the renal vascular disease, which is extremely important, is the RAS. RAS is basically the sclerosis or artery stenosis. Sorry, renal artery stenosis. So this narrowing has led to the renal artery stenosis. The main cause is atheroma. So before I talk about this morphology or how this occurs, this is the common structure or in a detailed view of your function of the kidney. The proximal tubule, the glomerular capillaries, finally the efferent and efferent arterioles. Now, notice the stenosis has occurred here. Efferent arterioles, where blood flow is reduced due to some trauma or certain reason, reducing the blood flow through this area. Now, this uh, blood flow will lead to the macula densa or lassus cells secreting the renin, and the process that I have told you previously will start to begin. So basically, this renal ischemia, as a result of the renal artery stenosis, leads to an increase in the production and release of renin from the juxtaglomerular apparatus, with a consequent increase in angiotensin II, and the entire effect that have occurred I have just described you here. Moving onwards, we will now further study a bit about this condition a bit more. Now, this RAS, I will now call this condition RAS now onwards. Usually, the imaging for this condition is usually indicated if there is evidence of an atheromatous vascular disease or a rise in the serum creatinine by more than 30%, abdominal roots, recurrent flashy pulmonary edema, or a renal asymmetry greater than 1 centimeter in length on the imaging. This is a histological view showing how this hypertension with the RAS usually occurs. Observe the juxtaglomerular cells, macula densa, and the lassus cell, which will secrete the renin, the efferent arterioles, and the distal convoluted tubule. This will mainly affect the your function of your kidneys. By when the stenosis occur here, this will lead to these cells secreting the renin, which will further aggravate the problem of the patient. So, moving onwards, we will continue with our lecture. Now, this is renal imaging done to identify pathologies, and it is the gold standard for diagnosing renal artery stenosis. And this is renal arteriography. This requires cannulation of the femoral artery usually, and it is less invasive imaging, MR or CT angiography or the Doppler ultrasonography. Now, as you can see here, after cannulation, a material injected which follow the pathway of the renal arteries, showing if there is any blockage or certain structure, if there is any evidence of ballooning, that shows there is an issue with the renal blood flow, as you can see over here. Otherwise, you can see the blood supply to the kidneys over here. So evidence of ballooning suggests any renal pathologies. Now, finally, class, we are going to talk about management. Now, the standard medical therapy for this uh, disease is mainly lifestyle modification, which involves increased exercise and thus stopping of smoking, statins, uh, antiplatelet therapy, and antihypertensives for effective blood pressure control. Transluminal angioplasty, as I have written here. Now, this transluminal angioplasty is basically to dilate the stenotic region, and stent placement is used in uh, uh, these patients. So that was enough about renal hypertension, its causes and mechanisms. Now we will talk about a very important topic, which is of significant importance. That is renal failure. So we will now talk a bit about what renal failure entails. Renal failure is basically an abnormal function of your kidney, or usually in this condition the kidneys are functioning at a level that usually 15% less than the normal. So there is a significant decrease in the function of the kidneys that leads to uh, an inefficient work of your kidney. So it is divided, or it can be classified into three types: the acute, the chronic, and the acute on chronic. First, we will talk about acute kidney injury. This is mainly an abrupt deterioration in the renal function, usually over hours or days, which is usually but not always reversible over days or weeks. It may certainly may be sudden and cause life-threatening biochemical disturbances, and is usually a medical emergency. Oliguria is a common feature. So let's talk in detail about this acute kidney disease injury or disease. I've just defined this condition. So what is important here, class, is it is to consider situations when urea or creatinine are less accurate predictors of developing renal function. Normally, urea and creatinine are the main tests that are used to identify pathologies related to the kidneys. Causes are three. First is prerenal, uh, usually caused by reduced kidney perfusion that leads to reduced or falling in the renal filtration rate. So if I show you the image above, okay, pre-renal means before the renal cause. If there is perfusion or pathology here, that will be pre-renal. Renal disorders, pathology of the structure itself. It can be an injury to the glomerulus, the tubule, or the vessels. And finally, the urinary tract obstructions. Postrenal, urinary tract obstruction are also called postrenal. So postrenal would usually entail that the functioning kidneys cannot excrete the urine, with the back pressure affecting the function. So post-renal, there is some pathology or an obstruction. This post-renal obstruction is hindering, not allowing the excretion of the urine, which will create a back pressure, which will affect the function of the kidneys. Pre-renal, renal, or post-renal, which is mainly urinary tract obstruction. Now we will talk about an important criteria that is associated with this uh, or classifying of this acute kidney uh, disease or injury. That is the RIFLE, or also called the rifle criteria. R risk, I is for injury, F is for failure, L is for loss, and E is for end stage renal disease. So let us talk about a bit more about this rifle criteria. Now, this criteria, I will describe a bit about it later, helps to identify or define the kidney disease. It describes three levels of renal dysfunction: R, I, and F. These describe the three levels of the renal dysfunction, and the last two, L, E, are the outcome measures. Uh, these are associated with a rise in the serum treatment or decrease in the urinary output. Normally, these criteria indicate an increasing degree of renal damage and have a predictive value for understanding the mortality rate of these conditions. Uh, for example, let me give an example that if the creatinine level is high, for example, greater than 1.5, then that person is at risk. If it is greater than 2, usually that person has a chance of injury. Greater than 3 is usually susceptible to kidney failure. If it is persistent acute kidney disease that persists for more than 4 weeks, there can be a loss. Or if there is persistent renal failure for more than 3 months, then at end stage kidney disease. So what I have just described you here is the rifle. R risk, I injury, F failure, L loss, E is for end stage kidney disease, and how the creatinine level affects or predicts what type of injury it correlates to. Similarly, the urine uh, uh, output criteria is measured in the same way. You can review it from the book how this is done. For your convenience, I have also added a chart which describes the criteria I just explained to you. Uh, Moving onwards. Now, how to approach or understand this condition even further. Let's talk about renal AKI. Renal AKI. Let's talk about this first. Now, in AKI, the falling renal blood flow leads to a falling glomerular filtration rate. Can be due to changes in the circulation or intrarenal vasomotor changes. Causes include, for example, hypovolemia, like dehydration, hypotension, like in shocks, low cardiac output, for example, cardiac failure or cardiogenic shocks, or in other causes can be due to ACE inhibitors, or even NSAIDs can cause this condition. Uh, Managing this renal condition (AKI) largely depends on the underlying cause. Most cases of this condition have an element of hypovolemia, as because of the prerenal pathology of lack of blood supply. So prompt fluid resuscitation is the most often indicated uh, treatment. Uh, Apart from that, heart rate, blood pressure, urine output will all guide a response to this resuscitation. Moving onward, we will now talk about post-renal kidney injury. Now, in post-renal, here in this condition, uremia results from the obstruction of the urinary tract at any point from the calcasis to the external urethral orifice. But uh, Even a prostate disease can also obstruct the bladder outflow, leading to post-renal AKI. Usually, these cases or some other unexplained causes of prerenal AKI may usually require an ultrasound to exclude this obstruction. And this obstruction, when removed, will lead to improvement in the symptoms. Now we will talk about renal parenchymal AKI, which is pathology of the kidney in itself. The most commonly known cause is actually acute tubular necrosis. Uh, Almost any cause of the prerenal AKI, if prolonged to the point at which renal autoregulation fails, it can lead uh, to uh, ischemic acute tubular necrosis. Uh, that is the most common cause of AKI. Other causes includes diseasing that affect the intrarenal arteries and arterioles, as well as the glomerular capillaries, or um, some embolism or hemolytic uremic syndromes can also lead to this condition. Other causes of this renal parenchymal AKI is acute tubular interstitial nephritis. This can also lead to injury disease. Usually occur when the renal tubules are acutely obstructed by crystals. So there's some crystal deposition. For example, after rapid lysis of some malignant tumors following chemotherapy. Finally, acute bilateral suppurative pyelonephritis or pyelonephritis can also cause acute uremia, which can lead to AKI. So, class, these three are the main: post prerenal, post-renal, or the renal parenchymal AKI. Apart from that, acute tubular interstitial nephritis or acute bacterial suppurative pyelonephritis can also lead to acute kidney injury or disease. Let's briefly talk about the clinical biochemical features of this condition. Number one is the alteration of the urine volume, oligo- oliguria. Now, this usually occurs in the early stages. The recovery of the renal function occurs after 7 to 21 days, and in the recovery phase, which may last some weeks, there is often a passage of large amounts of dilute urine. Now we will talk about the biochemical abnormalities or changes. These, for example, are hyperkalemia, metabolic acidosis, hyponatremia, hypocalcemia, etc. Symptoms of mainly uremia. The symptoms written here is mainly of the uremia, and they are weakness, fatigue, anaxia, nausea, and vomiting. It is then followed by mental confusion, seizures, and coma. Pruritus and bruising can also occur in this condition. Apart from that, impaired platelet function causes bruising and exacerbates the GIT bleeding. Infection can also occur due to immune suppressions. Now, let's talk briefly about the investigations, especially now. Especially if there is an emergency of this condition, uh, it can lead to serious pathologies. Commonly, cases include blood count, for example, anemia or very high ESR can be seen. Blood cultures are done to exclude infection. The dipstick test may suggest hematuria. Urinary electrolytes can help to exclude any pre-renal element of the AKI. Calcium, phosphate, and uric acid levels are important. Renal ultrasound is good to exclude any obstruction and also helps to give an assessment of the renal size. Uh, Histological investigations can include renal biopsy and should be performed usually in any patient, especially if there is an unexplained cause of the AKI. Optional investigations, these are dependent upon case by case. Uh, for example, serum protein electrophoresis can be done. Serum autoantibodies can be done. For example, apart from that, antibodies to hepatitis B and C can also be done in these cases and may suggest or may cause AKI. Usually, the management of this condition is typically preventive. For example, if you optimize the fluid balance in these patients, that can be done. Apart from that, uh, hypovolemia and obstruction must be excluded as contributing factors. Finally, good nursing, infection control are also important in improving the condition of the patient. Or, if needed, a specialist review who is a specialist in this field may also be done. For example, he can tell us whether hemodialysis, hemofiltration, or peritoneal dialysis is used. That depends upon the circumstance. So, a specialist can help us in this uh, regard. Finally, we will talk about principles of management of an individual or a patient with acute kidney disease. So, what are the principles of management of acute kidney disease? The first one is the emergency resuscitation. What is the emergency resuscitation procedure? Death from hyperkalemia can occur or due to pulmonary edema. Emergency resuscitation includes history, like the family history, systemic disease history, uh, assessment of the hemodynamic status. Next is prevention. Next is prevention of further renal damage. We have to stop this condition from deteriorating. For that, the early detection of infection and prompt treatment with antibiotics is indicated. Avoid hypovolemia, nephrotoxic drugs, NSAIDs or ACE inhibitors. Management of established renal failure. Uh, this usually includes, for example, seeking guide from a nephrologist, correcting the fluid balance, uh, good diet, nursing cares, for example, prevention of pressure sores. Similarly, even physiotherapists can give their guidelines in preventing pressure sores, or if there is any type of edema, we can suggest exercises or pressure stockings for these areas. Uh, Adjusting the dose of various medicines can be required. Uh, Daily blood chemistry, serum blood biochemistry should be observed, and it should be its condition later on should be reviewed if any dialysis may be required. Finally, in the end, is the careful fluid and electrolyte balance during recovery phase. A large volume of dilute urine may be passed until the kidney recovers its concentrating ability. So the fluid and electrolyte balance will help us understanding the recovery phase. So this is about the principles of management of an individual with acute kidney disease. I have briefly tried to explain the main principles. So they are mainly four. That is the first, emergency resuscitation, prevention of further renal damage, management of established renal failure, and careful fluid and electrolyte balance during the recovery phase. You can read the further details in the book. Now we will talk about chronic kidney disease. Our main topic was renal failure. We have discussed in great detail about acute kidney disease. Now we will talk about the chronic kidney disease. Usually, by the word chronic, it usually implies a long-standing and a progressive impairment in the renal function. Usually, this is what the chronic kidney disease entails. Definition is basically persistent, greater than 3 months evidence of kidney damage. The main indicators are usually proteinuria, hematuria, or any anatomical abnormalities with an impaired glomerular filtration rate. Patients that are at risk for this condition are individuals with diabetes or hypertension. Usually, these individuals should be regularly screened for this chronic kidney disease. Now, let us talk about the clinical features of this condition. Interestingly, the early stages of the renal failure are often completely asymptomatic. So, in the early phases of the disease, there are usually no symptoms. The patient does not typically show any classical signs. But with a declining GRF, glomerular filtration rate, and associated rise in the serum urea and creatinine concentrations, there is an accumulation of symptoms and signs, which we'll discuss now. So let us discuss some of them. First is anemia. Now, this anemia is primarily due to a reduced erythropoietin production by the diseased kidney. If you remember, class, that this erythropoietin is the hormone that helps us in the production of the red blood cells. This erythropoietin is actually secreted by our kidneys. So, reduced erythropoietin, reduced blood lead to anemia. Also, shortened red cell survival, increased blood loss, and dietary deficiency of irons can also contribute to this anemia. Next is your bone disease. There's a term called renal osteodystrophy. The term renal osteodystrophy embraces the various forms of bone diseases that develop in chronic kidney diseases. For example, osteoporosis, secondary or tertiary hyperparathyroidism, or osteosclerosis. Now, renal phosphate retention and impaired production of dihydroxy vitamin D leads to a fall in the serum calcium concentration. So, because of this, weakening of the bones may occur. So, kidney also have an important role in the uh, production of vitamin D, which is impaired. Neurological complications. When talking about neurological complications, these complications usually occur in all patients with severe CKD, chronic kidney disease, and usually dialysis improves them. Polyneuropathy manifests itself in these conditions in CKD as a peripheral paresthesia and weakness. Uh, Autonomic dysfunction presents as postural hypertension and the disturbed GRT, uh, gastrointestinal motility. Now we'll talk about the cardiovascular problems or cardiovascular diseases. The highest mortality in chronic kidney disease is from cardiovascular pathologies. Example: myocardial infarction, cardiac failure, or even stroke. Uh, this occurs due to an increased frequency of mainly hypertension or vascular calcifications. Renal disease also results in a form of cardiac myopathy with both systolic and diastolic dysfunctions. Finally, class other complications which can occur due to chronic kidney disease is for example, peptic ulcerations, acute pancreatitis, hyperuricemia, even erectile dysfunction, and increased incidence of malignancy. So these were some of the other complications. Now, it would be good to differentiate between an acute kidney disease or injury from chronic kidney disease. Now, distinction between these two depend on history, duration of symptoms, and previous urine analysis or measurement of serum creatinine. Normochromatic anemia, small kidneys or ultrasonography, and the presence of renal osteodystrophy favor a chronic process. So, if there is normochromatic anemia, you can write it on a page. A normochromatic anemia, small kidneys on sonography, and the presence of osteodystrophy. This usually represents a chronic process. As you can see that uh, anemia or decrease or shrinking of the kidneys and renal osteodystrophy is a time-consuming process, which is in a long-term process. Hence, it usually favors a chronic progression of the disease. Finally, we will talk about the management of this condition. Uh, First of all, we will briefly talk about the aims. Specific therapy, which is directed in understanding the underlying cause of the disease. Slowly deteriorating function of the kidney function. Uh, Kidney pathology, like I've told you, is a progressive issue. So slowing its deterioration is necessary. Usually, it comes under the term of renal protection. As cardiovascular diseases are an important issue, reducing the cardiovascular risk is important. Finally, if there is any complication, for example, anemia, we should treat it. Uh, Dose adjustment of prescribed drugs are based on the condition and it is uh, managed by the attending physician. So let us talk about slowing the process of the renal kidney failure, renal protection, which I just told you. The goal of renal protection should be to maintain the blood pressure at levels usually less than 120 by 80 millimeter of mercury, and to maintain a urinary protein concentration of less than 0.3 grams per 24 hours. So blood pressure should be less than 120 by 80 millimeter of mercury, and the urine protein concentration should be less than 0.3 gram per 24 hours. Good blood pressure control may slow the decline in the renal function. So blood pressure control is essential. Uh, if we talk about chronic kidney disease, uh, and if there is proteinuria greater than 1 gram per 24 hours, these individuals can receive ACE inhibitors, angiotensin receptor antagonists, diuretics if needed, and calcium channel blockers. Now, cardiovascular risk reduction is extremely important to improve the kidney function. Usually, it requires control of blood pressure and the reduction of proteinuria. For this purpose, statin can be given. Statin is medicine that helps to lower the cholesterol levels. Apart from reducing the cardiovascular risk, includes cessation of the smoking, not reducing cessation of the smoking. Smoking must be terminated immediately as it has a detrimental effect on the blood vessels apart from all other pathologies associated with smoking. Uh, Another thing that is important is to control the diabetes. And finally, uh, protein levels must be reduced, or a normal protein diet should be given in these individuals. Now, if we talk about briefly the complications, one is hyperkalemia. Usually, hyperkalemia responds good to dietary restrictions of potassium uh, intakes. Also, if there are drugs that can cause potassium retention, should be stopped. Other that hyperphosphatemia can occur in these individuals, and usually treated by dietary phosphate restriction and administration of oral phosphate binding agents. Uh, One example is of these agents is calcium carbonate. Anemia, very important complication. Now, iron deficiency is common in patients with chronic kidney disease and should be treated. Uh, Recombinant human erythropoietin is an effective but expensive treatment of anemia of chronic kidney disease. So that is one way of treating anemia. Recombinant human erythropoietin. If erythropoietin is less, an external dose of erythropoietin may uh, help in reducing the anemia. Apart from that, good iron diet is also effective. Uh, Also related to complication in kidney diseases is acidosis, specifically systemic acidosis. Now, the systemic acidosis usually accompanies the decline in the renal function and can contribute to increasing the serum potassium levels, even leading to dyspnea and lethargy. And as it is an acidosis, the treatment of this acidosis is usually with oral sodium bicarbonates. Finally, last is infections, which are is also an important complication. Now, patients with chronic kidney disease have an increased risk of infections, which can be fatal. Influenza and pneumococcal vaccination are usually administered in these cases. Dose adjustment is determined by the nephrologist or the attending physician. So this is all about the management of of chronic kidney disease. Now, class, we will briefly talk about benign enlargement of prostate gland. This is in your course. So this is the normal. This is the prostate gland. As you can see, how it is closely related to your urinary function. Now, this prostate usually has a role of increasing the volume of your semen, and it is uh, commonly affected by such as you can see here. This is the enlargement of prostate gland, benign prostate hyperplasia. This leads, as you can see here, to compression or narrowing the areas or obstruction which can hinder or obstruct the blood flow. Features are constant maturation or nocturnia. There's also delay in initiation of maturation. Individuals have difficulty in starting maturation due to the block, as you can see in this image here. This block, BPH is benign prostate hyperplasia, which has led to hindering in the blood flow. You can imagine the normal flow here and how the flow is obstructed over here. For post-void dribbling, it is basically after maturation. There is constant dribbling of the urine from uh, the area even after maturation is complete. Investigation is usually through serum electrolytes or renal ultrasonography. Management includes selective alpha-1 adrenal receptors antagonists. Now, this usually helps in improving the overall function of the patient. Or 5-alpha reductase inhibitors are also given in this condition. Finally, we will talk briefly about prostate carcinoma. Now, this prostate adenocarcinoma is common and accounts for 7% of all cancer in men. Now, this is a large image of this view here, and notice this area of tumorous growth. This is a carcinoma, and it will obviously may lead to swelling or extreme pain in this area. Features include the serum prostate specific antigen, or ultrasonography can be done to see any bladder outflow obstruction, which may help us refine the tumorous area. Diagnosis is usually made using a transrectal ultrasound of the prostate gland. Finally, we will talk about the management. Usually, the management is done by watchful waiting. Just because it is a tumor does not mean we have to panic. Simply viewing, watching, and waiting and observing is a good way of seeing the progression of this tumor. If needed, the treatment is usually confined to the prostate gland itself, and it is radial prostatectomy or radiotherapy. This is enough for you students to understand the brief treatment of prostate carcinoma. So class, this is all about our lecture for today. With this, I have finally completed your lecture about renal diseases. You are expected to view this lecture thoroughly, see, note any important points, study any key points that you have understood, and we will discuss it in our online session. So, thank you for attending the lecture. Goodbye.